Check on the other breast, left breast and axilla normal. And before saying this, you should also say that you examined the patient when the patient was sitting up and when the patient was lying down. This is very important in a patient with lesion. I will tell you why. But please do mention this, that the examination was done when the patient was sitting and when the patient was lying down. When you say this, the examiner automatically becomes impressed because the examiner knows that why did you examine the patient in two positions. Okay? So the left breast and axilla are normal. The right breast and axilla, the nipple areola complex is slightly at a higher level as compared to the left. Seems more prominent when the patient lifts both her arms up. There are prominent veins over the chest wall and the breast. There is an ulceroproliferative growth in the upper outer quadrant measuring 10 to 10 centimeters. We discussed the description of an ulcer in great detail. This I covered in clinical case of a leg ulcer in the common ulcer module. Also the oral ulcer which I discussed, there also I explained how to describe an ulcer in the exam. It has irregular margins, it has everted edges, there's slough on the floor with pale granulation tissue, there's foul smelling discharge, it bleeds on touch, and there is skin induration present as well. So you have a firm mobile lump as well, which is not fixed to pectoralis major muscle. I'll show you. Irregular margins are there, no other lump is present. So let me just show you the actual examination videos and tell you how these clinical signs are elicited when you are doing the clinical examination for a breast lump. So this video was recorded at Safdarjung Hospital, which is where I've done my undergraduate and my postgraduate and learned all my clinical skills. And you have to bear with the quality of the video because this was recorded when I was an undergraduate student. Okay? And we didn't have great cameras at that time. So please bear with the quality. Now you can see here that the patient is sitting and we ask the lady to raise her hands. By raising her hands, this accentuates any retraction or dimpling if it is present. And we also see if the nipple, if one-sided nipple is riding higher than the other side. So all these things we can get to know when we ask the lady to lift her hands up. Another thing which we have to see is whether the lump or the ulcer is fixed to the pectoralis major or not, right? So the first thing, before we do this test, first you ask the patient to bend forward, right? If the lump and the ulcer fall forward, we at least know that it's not fixed to the chest wall. If it did not drop forward, then at that time only we know it's fixed to the chest wall. Then there's no point doing the pectoralis major test. Now, to do the fixity to pectoralis major test, it is a three-step procedure, right? And I'll demonstrate those three steps. This is what you have to show when you get a case of a breast lump in your leg. First, you have to demonstrate mobility in two axes when the muscle is not taut. So right now, the muscle is not taut. You can see we are moving it in two axes. Okay? Next, we ask the lady to keep her hands on her waist and to press them tightly. Okay? Now she's pressing them. Then you check whether the pectoralis major has become taut or not. And then you look for mobility, right? Again, in both axes. And restricted mobility at this stage would represent that the lump or the ulcer is fixed to the pectoralis major. Okay. So the palpation, as we've discussed, is done when the patient is sitting and when the patient is lying down. We've described the ulcer. We've done the two major tests at hand raising and we've checked for fixity to pectoralis major. Now, another thing is that we have to examine the axilla. So in the axilla, the patient had a large central group of lymph nodes. There were 3 in number, maximum were 2 into 2 in centimeters, and mobile and bilateral supraclavicular fossae were normal. Right? Now, how do we examine the axilla? That is another very important clinical skill which you need to know. And I'll just demonstrate in the next video how exactly is it done. So to examine the axilla, in this case, we're examining the right axilla. Right? So my right hand is going to go on the patient's shoulder. As you can see in the video, my right hand is going on the patient's shoulder. And I'm going to do the examination with my left hand. Now, when my right hand goes on the patient's shoulder, we'll ask the patient to keep her hand against our elbow to support her hand. And then we'll start the examination. And then with the pulp of the fingers, never with the tips. If you are feeling with the tips, you'll never feel the lymph node. With the pulp of the finger, you palpate the axilla and you look for lymph nodes. So this way we can look for the anterior, central, apical group of lymph nodes. And the lateral group of lymph nodes is felt with the other hand. And then in the next video, you'll see how do we look for the posterior group. So now what we're going to do is we ask the patient to keep her hand on the opposite shoulder and then feel from the back for the posterior group of lymph nodes as well. That is how we feel for the posterior group of axillary lymph nodes. So this is how we do an axillary examination. After this, we look for the supraclavicular fossae and the neck lymph nodes. So this was a local examination, and the general examination of the patient was normal. Then the examiner asks you what is your diagnosis or what is the impression at the end of your history and physical examination. So you're going to say that this is a 45-year-old postmenopausal lady. This postmenopausal is very important for me because it has a bearing on the treatment. With fungating growth in the right breast, which is suggestive of a locally advanced breast carcinoma. And the clinical stage, so remember, we will write it as CT4B. Why C? I told you in the module that when we are doing clinical staging, we write it as CT4B, N1, and previous modules I've also told you, I'll write it as MX. Because typically I cannot say whether there are meds or not, so MX means cannot be assessed. This is a better answer than saying M0. Please remember this. You will say cannot be assessed. CT4B, N1, MX will be my clinical diagnosis in this case. Now, when the examiner is going to ask you, in this case, it's very difficult for there to be any differential because it's a very clear-cut case of malignancy. Why is it a phylloid tumor? Well, phylloid tumor, there can also be rapid increase in size in the phylloid tumor, but phylloids will not usually fungate like this. Okay. And the second thing is phylloids tumor, does not go to the axillary lymph nodes. Here you have proper nodes palpable. So those are the 2 points which are against phylloids tumor in this patient. Now, the next thing is that how do we work up this patient? So the examiner is going to ask you, how will you work up this patient? And I've told you, whenever you're asked this question, you have to say, I'll do investigations to confirm the diagnosis. I'll do investigations to stage and support my diagnosis, stage and support the disease or the diagnosis, and I'll do investigations to treat the patient. This is how you could answer in the exam. When you answer like this, the examiner knows that you're thinking logically and you're just not randomly babbling out investigations. You're thinking with a very clear mindset. Investigations to confirm the diagnosis, you'll have to do a biopsy. And when you have an ulcer or proliferative lesion like this, we've discussed many times, if I have to take a biopsy, it will be an incisional biopsy here. It will be an incisional biopsy, and I'll take it from the edge of the ulcer. We take an edge biopsy. Why not from the center? Because we've discussed that the center is necrotic. So we take it from the edge of the ulcer. To stage the disease, we've discussed staging. We can do a PET CT that will tell us the complete staging of the patient. And the investigation would be a routine pre-anesthetic checkup. Investigations, the blood work, ECG, X-ray. This is how we work up the patient. The management, the management of a locally advanced breast carcinoma. In the previous module, I told you how do we treat a locally advanced breast carcinoma. We are going to give neoadjuvant therapy. Neoadjuvant chemotherapy will be there. That will be followed by modified radical mastectomy. That will be then followed up with radiotherapy. If ER/PR is positive, then we are going to give hormonal therapy to this patient as well. Another thing which I want to clarify here is that why is this T4E? Because skin is involved. And what are the 3 things which make it skin involvement? Ulceration, satellite nodules, and UV run. So here you have ulceration, so it is T4B. And because it was not stuck to the chest wall, that is why chest wall involvement is not there in this patient. So this was a case of breast cancer. I've told you the history and I've shown you how the examination is done. I've also told you how to work up this patient and manage such a case. So now I'm going to show you small clips of MRI and breast conservation surgery. We've already discussed the details in the previous module. This is just an idea regarding the various steps involved in this procedure and just to make the understanding of these procedures better. So first we talk about modified radical mastectomy. So in modified radical mastectomy, the first thing is the positioning of the patient. So the positioning of the patient has to be the patient is in the supine position, the arm is outstretched. We make sure that the arm is not abducted more than 90 degrees. And after cleaning and draping, then if I have to do a sentinel lymph node biopsy, you can see here that I'm injecting the methylene blue, which is blue dye in the perialveolar region. Then I make the elliptical towards incision, which we've discussed in the module as well. And after doing this, we use these skin hooks. You can see that the nurse is using the skin hooks, and I'm using the monopolar cautery to raise the skin flaps, right? So using the monopolar cautery to raise the skin flaps. Once I've completed dissection of the superior flap, I can see the pectoralis major muscle. After that, I move on to the lower flap. The lower breast flap is more adherent as compared to the superior flap. So it's always slightly more challenging to raise the lower flap as compared to the superior flap. Once we've raised the lower flap, then I start dissecting the breast of the pectoral fascia. You can see here the pectoralis major muscle. The tiny structure which you can see is the pectoral fascia, and I'm dissecting the breast tissue over that. Once I've done this, then I'm going to enter the axilla, right? We enter the axilla, and I will first search for the sentinel. Okay. Now I'm entering the axilla here. So I'm entering the axilla. You can see the blue lymph node, the blue dye which I had injected. You can see the blue lymph node, the sentinel lymph node in this case, and it is stained blue. We remove it, we send it for frozen section. If I'm using a dual technique, then I'll also use my gamma camera to see if it is showing increased radioactivity. Once I've dissected this, I send it for frozen section. In this case, the sentinel lymph node turned out to be positive for cancer after frozen section. So after this, I proceeded with the axillary lymph node clearance. 1 out of 4 lymph nodes were positive. So you can see here now I am dissecting the axilla. You can see the axillary vein coming into view. This is the axillary vein. And because I'm lateral to the pectoralis minor, lateral to pectoralis minor, the level 1 lymph nodes. So this is where I'm doing the level 1 lymph node clearance. This instrument which I'm holding in my right hand, I'm left-handed, so I use the cautery with my left hand. The right-handed instrument is known as Rushton forceps. I have shown it in the instrument module, and I use this when I'm doing lymph node clearance. You can see here that I'm dissecting the lymph nodes. And I'll show you the endpoint of dissection. This is level 3 clearance. You can see that the nurse is retracting the pectoralis major and also the minor. So I'm operating medial to the pectoralis minor. So that becomes level 3 lymph nodes. You can see the endpoints. I've shown this image in the module as well. Thoracodorsal pedicle, axillary vein, Halsted ligament medially, and the angular vein. This is what it looks like after we've done the surgery. Then I'm going to close the incision. And in this case, I had used staplers. So these are skin staplers after drain insertion, where I had closed the incision after this. So this was a patient with modified radical mastectomy. I'll show you another clip of a breast conservation surgery for a patient which I've done, and that would clarify the concepts regarding BCS as well. So you can see here the tumor. You can see the tumor here on the right side. This is the tumor. This was a mother of a medical student, and she had come to me with an early breast cancer. But she just had one demand. She said, I want the breast to be saved. And second, I have a flight booked for Singapore in 15 days' time. I want to board that flight. You need to make sure that I board that flight. So I very distinctly remember this case. Now you can see that two incisions would be made. This is over the lump. I made the incision, and another marking of the incision over the axilla. Right. So first I'm doing the lumpectomy. I will remove small amount of skin. I raise the skin flaps. We raise the skin flaps. And my finger, you can see the finger which is inside the cavity is constantly feeling the lump. So I'll make sure that I get adequate margins. I'll go beyond the boundaries of the lump. Okay. So this is just a section of the lump. I'm getting adequate margins here. Once I've raised adequate skin flap, then I'm going to do the lumpectomy. I'll remove the lump. You can see here I've started removing the lump now, and I'll go right down to the pectoral fascia. Very important thing when I'm doing the breast conservation surgery is that I have to mark the specimen, I have to label the lump, and I have to label which side is superior, which side is lateral. Because when I send it to the pathologist, they will be able to tell me which all margins are closed, which are clear. So you will see later on that when I do the labeling before I cut the specimen out of the breast, and we put a short superior and a long lateral suture. And that is the standard orientation which the pathologist also knows about. So you can see here, I'm taking that suture. I take a short superior and a long lateral suture so that my pathologist knows which is which side. So once I've done this, then I disconnect the lump from the breast. And once I've done that, this is the lump. You can see the lump goes for specimen mammography. That is one way how I get to know whether my margins are clear or not. And it also goes for a frozen section after that. You can see here the pectoral fascia. You can see the incision I've shown, the section I've shown in the previous videos. I'm not showing the dissection in this video. This is the axillary incision, and I just do the axillary dissection as I did in the last video which I showed to you. So this is just here entering the axilla. And coming back now to close the cavity. Before I close the cavity, I mark the boundaries with clips. These clips are important because I told you that radiotherapy is mandatory after breast conservation surgery. So the radiotherapist gets to know what was the base of the tumor, and they can give a boost there. Now you've seen I'm closing the incision using subcuticular sutures. This is after subcuticular sutures, the drain has been inserted. And you can see this is 2 weeks post-operative. This is on the day when she had to board the flight. She came in the morning and just for a final examination before she left for Singapore. You can see that the cosmetic result was good. She was happy with the result and we were able to clear the tumor. After 1 month, you can see the scars fade out even more and the breast shape and size is maintained. So that is the advantage of breast conservation surgery over a mastectomy, that cosmetically and psychologically it is better for the patient because there's no loss of the organ. So in this module, I told you about a clinical case and I've shown you the operative videos. This is not only useful for the final year students, but also for those who are appearing for the entrance exam. It will give you an overview of how to answer clinical questions in the exam. So in this module, we'll talk about the actual management of breast cancer. In the previous module, we've spoken about the types of breast cancer, we've spoken about the risk factors, we discussed the staging. Now we actually move on to the management. So we know that the treatment modalities for breast cancer, you have 4 treatment modalities. So you have surgery, you have chemotherapy, radiotherapy, and hormonal therapy. So surgery, chemo, radiotherapy, and you have hormonal therapy. Now, all patients don't require all modalities. We discuss the indications of each one of them. Okay? So first, let's talk about surgery. And surgery in any patient with breast cancer, you will have to take into account 2 things. You have to do surgery for the primary tumor, which is in the breast, and you have to do surgery for the lymph nodes. So these are the 2 headings under which we'll talk about the surgical management of breast cancer. Now, primary tumor surgery. So primary tumor surgery, you can have 2 types of procedures which can be done. You can either do breast conservation surgery, we can either do breast conservation surgery, or we can carry out mastectomy. Now, whenever a patient comes to me with breast cancer, I will discuss both the options with the patient. And when I tell the patient that whether you opt for breast conservation, where we save the breast and we just remove the lump, or you opt for full removal, the overall survival, whether you do BCS or you do mastectomy, is the same. There is no difference in the overall survival. But what is different? So the patient asks, then what is different? So what is different is the loco-regional recurrence rate. LRR is the loco-regional recurrence rate. Means the risk of cancer coming back at that local site. That is 3 to 4% with breast conservation surgery, and it is approximately 1% or less than 1% with mastectomy. So there is a difference of 2 to 3% in the loco-regional recurrence rate when we carry out breast conservation surgery. Which is why if I'm doing a breast conservation surgery, we tell the patient categorically that they will require radiotherapy after surgery. So radiotherapy is mandatory if breast conservation surgery is done. If BCS is done, then radiotherapy is mandatory after surgery. This is something which we have to tell the patient. So like I told you, there are two types of surgeries which can be carried out. You have breast conservation and you have mastectomy. First, we are talking about breast conservation surgery. So breast conservation surgery is nothing but a lumpectomy, right? So this is the lump. If this is the lump, I am going to remove the lump with a normal rim of tissue, with a margin of normal tissue. So breast conservation surgery is nothing but a lumpectomy. And the margin status has undergone a lot of revision in a few years since I've been practicing. So ever since, we were postgraduates, we used to learn that we have to take 1 to 2 centimeter margin, right? 1 to 2 centimeter margin is to be taken. But now the margin status is 1 millimeter, or at certain places, even in Bailey, they've written there should be no tumor at ink. If there is no tumor at the margin, then that means it is negative margin status. You don't require a very, very long margin status that does not reduce the local recurrence rate. So this is the margin status now, 1 millimeter or no tumor at ink is what we follow when we carry out breast conservation surgery. So breast conservation surgery, another term which I want you to know is oncoplasty, right? Oncoplasty is a term which combines two things. It combines the principle of cancer surgery, that means onco, and plasty means the principles of plastic surgery. So by doing oncoplasty, we can ensure that we are removing a tumor and we give a cosmetically appealing breast to the patient after surgery. Now, there are two types of oncoplastic procedures which we can do in breast conservation surgery. We can do volume displacement and we can do volume replacement. Now, volume displacement is still 10 to 15% breast volume resection. So after 10 to 15% breast volume resection, we can do volume displacement. Whereas volume replacement is if it is more than 15% breast tissue is resected, then replacement has to be done. Displacement basically means that if I've cut some tissue, if I've cut less than 15% of breast tissue, I can just mobilize the pillars and I can close that defect. So I will show you a video in some time where I've done a very simple oncoplasty so that you understand this principle, where there was a defect and after mobilizing the tissue, I have closed that defect. So you can see the defect here and I've just mobilized the tissue to close the defect. This is volume displacement. Volume replacement is when we remove more than 15% breast tissue and we don't have adequate tissue to close there. So then we are going to get tissue from somewhere else. We are going to replace that tissue and that is volume replacement. So we will carry out flaps to replace that tissue and that is volume replacement surgery. So these are the two types of oncoplasties which are there. There are three levels of oncoplasty. That is all I want you to know. More than that is not required for your postgraduate exams. If somebody is preparing for the SS exam, yes, you can know the details. But for post-graduation, just know that you have volume displacement and you have volume replacement. That's all. So these are some patients of mine where I've done an oncoplasty. So you can see here, this is type 1 oncoplasty which I've done, where I just done a periareolar incision, right? A periareolar incision was made and we had done the oncoplasty and you can see that there's a cosmetically appealing breast tissue after surgery as well. This was a patient where we done volume replacement, where, we had removed a large bulk of the breast tissue and we had supplemented it using a LD flap, a latissimus dorsi flap, which I've already discussed in the plastic surgery module with you. So this was regarding breast conservation surgery. One more thing which I want you to know, that the most common site for breast cancer is the upper outer quadrant. This we discussed is the upper outer quadrant. That is the most common site for breast cancer, the upper outer quadrant. And upper outer quadrant is the most common site where oncoplasty can be done. Oncoplasty can be easily done, right? Can be easily done in this area. And the most difficult area where we can do oncoplasty is the upper inner quadrant. This upper inner quadrant is known as the no man's zone. And this is the most difficult place to carry out oncoplasty because there's very little breast tissue available here. This was asked in the INICD exam and also the NEET SS exam, so it can be asked in the PG exam as well. So you should know about this. Now let me just show you a video where I've demonstrated a breast conservation surgery, a very simple oncoplasty which I've done years back where I've mobilized the tissue. So that is the thing which I want to show you in that video. So this is the video in which I demonstrate breast conservation surgery to you. This was a 49-year-old patient of mine. She was actually a relative of one of the students, and she had come to me with a tumor in the right breast, and she wanted a breast conservation surgery. So you can see that there are two incisions which have been marked. One is around the tumor, and one is for the lymph nodes. We knew in her case that the lymph nodes are positive, which is why it's a slightly bigger incision for the lymph nodes. So this is a very basic oncoplasty which I recorded many years back. I just wanted to show what volume displacement means when we mobilize the flaps and close them. Right? So here you can see I've made the incision and I'm raising the skin flaps, and I'm using a monopolar cautery to raise the skin flaps. So we're raising the skin flaps. Once the skin flaps have been raised sufficiently, once we've gone beyond the tumor, then we are going to carry out the lumpectomy. We're going to remove the tumor with adequate margins, and then I send it out for frozen section. So you can see here, I'm just mobilizing all around the tumor, and once I've done that, then I'm going to carry out the lumpectomy. These are skin hooks which are being used. Skin hooks are being used to raise the skin, and now you can see I've started the lumpectomy. And we also have to label the specimen. We have to mark the specimen so that the pathologist knows about the orientation. Okay? So now the lobectomy is being done. We're carrying out the lobectomy in this case now. Right, so I'm going to go all around and I go right down to the pectoral fascia. So you will see the pectoralis major muscle fibers. I'm going to remove the pectoral fascia as well. So you can see now the tumor is being cut. That is the tumor, which is the lobectomy is being done. And I'm right down to the pectoral fascia. I'll show you the pectoralis major muscle fibers as well. Now this is me marking the specimen. It's a short superior long lateral suture. Okay, short superior long lateral, ink at base. I put ink at base so that the pathologist can orient the specimen. Otherwise, if you just send a specimen like this, the pathologist will have no idea which part. So short superior long lateral, ink at base. That's how we label it. So just disconnecting the specimen now. That is the specimen. We also do a specimen mammogram sometimes to see that adequacy of the specimen. This you can see the pectoralis major muscle fibers. We remove the pectoral fascia as well. And this is the defect. And you will see how I mobilize the tissue to cover up this defect. This is the axillary incision being made. This is the axillary incision which is being made. Then the axillary dissection would occur, which would take place. That I've also demonstrated in the mastectomy video. So this is just the axillary incision. And I skipped the axillary dissection part because I've covered it in the mastectomy video. Now you can see I'm labeling the cavity with clips for radiotherapy, and we put clips there. And now I've started mobilizing the tissue. Can you see the entire cavity has been filled up? We mobilized tissue from the side and we filled up the cavity. Now we use subcuticular incisions to close the cavity. That is the drain which has been inserted. And now you will see the follow-up pictures. This was 2 weeks post-operative. I remember this patient had come to me. She had to go to Singapore after 15 days. So in the morning she had come and then she had boarded a flight to Singapore. And you can see that the scars are faded out a bit. And you will see then 1 month follow-up when she came back. This is after 1 month, and you'll see that the scars would fade out even further, but the prosthesis and the shape of the breast is maintained. That is the advantage of breast conservation surgery. Now, we cannot carry out breast conservation surgery in all patients. There are, of course, contraindications for breast conservation surgery. And I like to divide these contraindications of breast conservation surgery into contraindications for radiotherapy, because we know radiotherapy has to be given, and technical contraindications. That's how I like to divide them. So contraindications for radiotherapy are pregnancy. If a patient is pregnant, then we cannot give radiotherapy. This is an absolute contraindication. The other contraindications, which are relative contraindications, are active SLE, rheumatoid arthritis, or scleroderma. Right? These are all collagen vascular diseases. Where radiotherapy is relatively contraindicated because there are more complications when you give radiotherapy in these patients. Right? So because of more complication risk, it is contraindication. And if there is prior radiotherapy exposure to the chest wall, if the patient is already received radiotherapy to the chest wall previously, that is also a relative contraindication. Although with newer techniques, after a few years, you can repeat radiotherapy to the chest wall as well. The technical contraindications, the absolute contraindication is multicentric disease. Multicentric, we discussed one tumor here, one tumor in another quadrant. So multicentric disease is an absolute contraindication. Multifocal disease is a relative contraindication. Multifocal means more than one tumor in the same quadrant. That's a relative contraindication. You can still do breast conservation surgery there. Other contraindications are lobular cancer. Why is lobular cancer a contraindication? Because we discussed lobular cancers can be multicentric and bilateral. So if you have a multicentric lobular cancer, we will avoid breast conservation surgery in these patients. If it's a large tumor to breast ratio, right? Where if you have a very large tumor and the breast size is not much, so we will not be left with meaningful breast tissue. Okay. Why is this a relative contraindication? Because we can always give chemotherapy first. And what is that known as? Neoadjuvant chemotherapy. Correct. We give neoadjuvant chemotherapy, we shrink the tumor, and then we can carry out breast conservation surgery. So these are some of the contraindications for breast conservation surgery. I want you to know that family history, central quadrant tumors, and positive lymph nodes are not contraindications for BCS, right? These questions have been asked in the exam. So these are not contraindications for breast conservation surgery. Now, this was regarding breast conservation surgery. The other option which we have is called mastectomy. Now, this was regarding breast conservation surgery. The other option which we have is called mastectomy. Now, mastectomy, when it started, radical mastectomy was done. Radical mastectomy was described by Halsted. Halsted was the surgeon who described radical mastectomy, and that involved the removal of the breast plus the nipple areola complex, that is NAC, nipple areola complex, plus the pectoralis major plus minor, and level 1, 2, 3 axillary. So we were very radical in the surgery, and the pectoralis major and minor both were removed, and that led to a lot of functional impairment. And what was seen was that even after removing so much, the outcomes were the same. Okay, whether you leave the major or the minor, or you remove the major or the minor, the cancer outcomes were the same. Which is why these days we carry out modified radical mastectomy (MRM). So in MRM, the points which you should, the incision which is used is the elliptical Stewart's incision. This I'll demonstrate in the video which I show you as well. Elliptical Stewart's incision is used. This has been asked in the exam. And modified radical mastectomy involves the removal of the breast plus the nipple areolar complex. So we remove the breast plus the nipple areolar complex. We remove the pectoral fascia, not the pectoralis major, the pectoral fascia. We remove level 1, 2, 3 lymph nodes, axillary lymph nodes, and plus minus pectoralis minor. Plus minus pectoralis minor is removed. Why am I writing plus minus pectoralis minor? Because there are modifications of MRM. You have the Auchincloss modification, you have Auchincloss, you have Scanlon, and you have Patty. These are the three modifications. And in Auchincloss, which is most commonly done, the pectoralis minor is just retracted. We don't cut it, we just retract it. Okay. Whereas in Scanlon and Patty, the pectoralis minor is cut. So that is why we plus minus pectoralis minor. So this is modified radical mastectomy. Of course, I'll show you a video and I'll tell you the boundaries of axillary clearance as well in some time. Another option is simple mastectomy. Simple mastectomy is when you're just removing the breast plus the nipple areolar complex and the pectoral fascia, but lymph nodes are not removed. Lymph nodes are not removed. That is simple mastectomy. And simple mastectomy can be done for conditions like phylloid tumors. Right? We'll talk about phylloid tumors later. And in phylloid tumors, I'll tell you that less than 10% phylloid tumors go to the lymph nodes. So because less than 10% are going to the lymph nodes, we unnecessarily don't need to remove the lymph nodes there. So there we can do a simple mastectomy. Another indication for simple mastectomy, that is known as toilet mastectomy. So toilet mastectomy is a palliative procedure. Toilet mastectomy is like simple mastectomy only. And this is a palliative procedure in fungating cancers. Palliative procedure in fungating cancers. We can carry out a simple mastectomy known as toilet mastectomy. So these are the various types of mastectomies which are there. Let me show you a video of modified radical mastectomy. And I would say the key steps which you need to know for your exam. So this was a 46-year-old patient of mine who had a T2N0M0 lesion, and we were doing a mastectomy. She did not want a breast conservation surgery. We were doing a mastectomy with a sentinel lymph node biopsy. You can see I'm injecting the blue dye in the periareolar region. This is the elliptical Stewart's incision which is used for mastectomy. Here I'm making the incision, and after making the incision, we raise the skin flaps. These are the skin flaps. The superior skin flap which is being raised. We use skin hooks. The nurse uses skin hooks to give traction, and I carry out using a monopolar cautery to raise the skin flaps. Now, once we reach till the clavicle, that is when the superior skin flap is complete. Then skin flap. The skin flap is more adherent, and it is more difficult to raise the inferior skin flap than the superior skin flap. So this is the inferior skin flap being raised, and we go till the inframammary fold. So this is the skin flap, and the skin flap should be of adequate thickness so that necrosis does not occur. Now, once we've done that, then I remove the breast tissue along with the pectoral fascia. You can see that I'm removing it along with the pectoral fascia, and you can see the pectoralis major fibers, right? The fascia has been cleaned up, the glistening tissue has been cleaned up, only the fibers are being seen. We are going to carry out this mastectomy, and as we lift the breast, we will enter the axilla. We are entering the axilla. See the blue lymph node, which is there, the sentinel lymph node. That dissection also I'll show you. And once we identify the sentinel lymph node, you can see the sentinel lymph node coming into picture, the bluish lymph node. So we're going to dissect the sentinel lymph node and we send it for frozen section. So we trace the lymphatics and all the blue lymph nodes and all the hot lymph nodes. We do the dual technique and the ICG technique, which I've told you, that can also be done. And we remove the lymph nodes. So you can see the sentinel node being dissected. And once the sentinel node has been dissected, we send it for frozen section. Now, one lymph node came out as positive, which is why I proceeded with an axillary lymph node clearance. I've already shared the boundaries of axillary lymph node clearance. You can see the axillary vein coming into picture now. That is the axillary vein, that is the superior limit of axillary dissection. So I dissect out the branches, whichever are the superficial branches. We apply clips there. We ligate those branches. The thoracodorsal pedicle, of course, we don't like it. We have to save the thoracodorsal pedicle. That also I will just show you. Also, on the medial side, we are careful about the long thoracic nerve, which also I will just demonstrate. So we're removing the tissue, you can see, and the long thoracic nerve is along the chest wall, that is safe. So this is level 3 axillary clearance. You can see the assistant is retracting the major and the minor, and we are dissecting below that. So these are the boundaries of axillary clearance. This image I've already shown you in the module. You can see the long thoracic nerve also running along the medial chest wall. Once this is done, then the cavity is washed. We put in drains, we put in negative pressure drains, and we close. Now, like I showed you in the video, once we carry out an axillary clearance, if I'm doing an axillary clearance, then minimum 10 lymph nodes are to be removed. Minimum 10 lymph nodes are to be removed. Of course, we don't need to do this in all patients. We can carry out sentinel lymph node biopsy, which I'll tell you in some time. What are the indications for that? But if you are doing an axillary clearance, minimum 10 lymph nodes are to be removed. And the boundaries of axillary clearance are very important. They've been asked many times in the exam. The axillary vein is the superior boundary. Thoracodorsal pedicle, which you can see, this was a patient where I have the dissection. You can see it very well. Thoracodorsal pedicle supplies the latissimus dorsi muscle. That is the lateral boundary. Angular vein is the inferior boundary, and the Halsted ligament is the medial boundary. Now, one thing which I want you to remember here for the exam is that this long thoracic nerve, the long thoracic nerve runs along the chest wall. So the long thoracic nerve supplies which muscle? Correct. It supplies the serratus anterior, right? Supplies the serratus anterior. So we need to save the nerve, but it is not a boundary of axillary clearance. So these boundaries you should know. The structures which are saved in MRM, this has also been asked in the exam. So axillary vein, thoracodorsal pedicle is saved. Then we have to save the long thoracic nerve, pectoralis major, plus minus minor, and the lateral and medial pectoral nerves. So these are the structures which are saved in MRM. Questions have also been asked this way. Which structures are saved in MRM? So these are the structures which we save. Now, what are the complications of mastectomy and axillary clearance? These have been asked frequently in the exam as well. So, of course, bleeding can occur. Bleeding can be during surgery, or it can be reactionary hemorrhage or secondary hemorrhage later on. There can be injury to the nerves. Now, very important for the exam, which is the most common nerve injured during MRM? And whenever I ask this question, majority of the students answer the long thoracic nerve. That is the wrong answer. The correct answer is ICBN, intercostobrachial nerves. The intercostobrachial nerves. These are the most commonly injured nerves during surgery. This has been asked in the exam. And the intercostobrachial nerves are the sensory nerves which supply the axilla and inner aspect of the upper arm. Right? So they supply the axilla and the inner aspect of the upper arm. And these sensory nerves, if they are injured, you will have the patient who will tell you that I have altered sensation in the axilla. Right? If I'm doing a shaving or a waxing of hair, or if they're applying an underarm deodorant, they will not get sensation, or they'll get altered sensation, and that is because of intercostobrachial nerve neuralgia or injury. The other nerve which can be injured, you can have the long thoracic nerve which can be injured. The long thoracic nerve is also known as the nerve of Bell, or the nerve of serratus anterior. It supplies the serratus anterior muscle. And if this nerve is injured, it gives rise to winging of scapula. As everyone knows, it has been asked multiple times in the exam. Long thoracic nerve injury gives rise to winging of scapula. See here, this image has been asked in multiple exams. This is winging of scapula thoracic nerve injury. There can be thoracodorsal nerve injury. Thoracodorsal nerve injury will give rise to weakness of the latissimus dorsi muscle. And lateral and medial pectoral nerve injury. Lateral and medial pectoral nerve injury will give rise to pectoralis major and minor quickly. So continuing with complications of breast surgery, it can be flap necrosis. If there's inadequate blood supply to the flaps can necrose. They can become dusty, and that is flap necrosis. The most common complication is seroma formation, and this has been asked in the exam. Seroma formation is collection of fluid beneath the flaps. It's collection of fluid beneath the flaps. That is seroma formation. And this is the most common complication following breast surgery or mastectomy, which is why we put in a closed suction drain or a Romovac suction drain. So this you can see, this is a Romovac negative pressure drain, which is also a closed suction drain, which was asked in the INI-CD exam as well. This is a closed suction drain, which is put in after every surgery, especially when we are clearing the axillary nodes. So I put in this closed suction drain. I told you about this closed suction drain in the module on general surgery about drains. I told you how it functions, how we pressurize this closed suction drain, how do we empty the drain, all those things I've told you in that module. So we put in this drain after breast surgery to prevent seroma formation, and the drain is removed. When do I remove the drain? The drain is removed if the output is less than 40 cc per day for 2 consecutive days. The output is less than 40 cc per day for 2 consecutive days. That is when we remove the drain. If the drain is moved early, fluid can accumulate, and that is known as seroma. And there was another question asked in the exam where they had asked that a patient accidentally the drain comes out, right? Accidentally the drain comes out, and the patient comes to you with a swelling in the region of the surgery. And when you do an ultrasound, there is fluid collection or a seroma there. So if a seroma is present, then what we have to do? Carry out aspiration. Then we have to carry out aspiration under aseptic conditions and do pressure dressings. And do pressure dressings. That is what we have to carry out if there is a seroma. If there is a seroma formation, this is what we do. We use drains to prevent seroma formations. Another complication following mastectomy and axillary clearance is lymphedema. So lymphedema is swelling of the upper limb. This will be swelling of upper limb in this case. And post-mastectomy lymphedema, I told you, is the most common lymphedema. Post-mastectomy lymphedema is the most common cause of lymphedema. Most common cause of upper limb lymphedema is post-mastectomy lymphedema. Overall, the most common cause covered in the lymphatic disorders module is filariasis, but causes post-mastectomy lymphedema. Now, this post-mastectomy lymphedema would manifest a few months after surgery. It would manifest few months after surgery, and the patient will complain of swelling and dull pain. Swelling and dull pain is how the patient is going to come to us. And the risk increases, the risk of lymphedema increases if axillary clearance is done, axillary lymph node clearance is done versus sentinel lymph node biopsy. So higher risk when axillary clearance is done, or if clearance is done plus radiotherapy to axilla. So if clearance is done and radiotherapy is also given to the axilla, then the incidence increases further, which is why we only do one of them. We either do axillary lymph node clearance or we give radiotherapy to the axilla, right? Remember, remember there is no link. There is no link between seroma formation and lymphedema. So there is no link between seroma and lymphedema. A lot of patients think that if seroma is forming, then arm swelling can also develop. There is no link between the two. Please remember that. Right, so these are the points regarding lymphedema. And this is how the patient comes. The patient comes with the swelling of the upper limb. I've already told you the management of lymphedema in great detail in the lymphedema module. So here we tell the patient to do lymphedema exercises. Lymphedema exercises are told to all the patients. They have to wear stockings, right? Arm stockings are worn. Arm elevation is done. And also pneumatic compression stockings, which are there, which I've shown you in the lymphedema module, which can be used. This can also reduce lymphedema. One of the most dreaded complications of lymphedema is Stewart-Trevis syndrome. And this question has also been asked multiple times in the AIIMS exam. Stewart-Trevis syndrome can develop in long-standing lymphedema. Right? So the question stem would say that there is a lag of 8 to 10 years. So the question would say that the patient had a breast surgery 8 to 10 years back and had swelling of the arm. And after 8 to 10 years, the patient has come back to us with bluish or reddish nodules. Bluish or reddish nodules over the upper lip. Bluish or reddish nodules are nothing but angiosarcoma or lymphangiosarcoma, and that is known as Stewart-Trevis syndrome. So this is angio or lymphangiosarcoma, which can develop if there's long-standing lymphedema for more than 8 to 10 years. Then this angiosarcoma or lymphangiosarcoma, that is Stewart-Trevis syndrome, can develop. Now, a word of caution here, right? Both the questions have been asked. If you get a question stem which says that a patient develops a swelling few months after surgery, right, and they show you an image like this, then the answer is going to be lymphedema. But if they say that the surgery was done 8 to 10 years back, there was swelling of the arm, and now recent onset bluish or reddish nodules are there, then it is Stewart-Trevis syndrome or angiosarcoma or lymphangiosarcoma. So there are two separate things. I don't want you to get confused. If there is angiosarcoma or lymphangiosarcoma, the management is 4-quarter amputation. 4-quarter amputation is when you disarticulate the upper limb along with the scapula. Disarticulate the upper limb along with the scapula, and usually these patients have a poor prognosis. Another complication following mastectomy. Disarticulate the upper limb along with the scapula, and usually these patients have a poor prognosis. Another complication following mastectomy is local recurrence. So they can be recurrence at the operated site. This was a patient who had a mastectomy and she come to me from Bihar and she did not receive any chemo or radio after surgery. And she came to me 2 years later with a recurrence on the medial side. This was a local recurrence. And whenever there's a local recurrence, how do we manage these patients? So first of all, we need to do imaging. We need to carry out imaging, and MRI is the best imaging modality to document local recurrence that I covered in the first module. Even after breast conservation surgery, if there is a local recurrence, we document using MRI. Then we also have biopsy of the local recurrence. Why do we need to do a biopsy? To confirm the diagnosis and to see the ER, PR, HER2 status. Now you remember these IHC markers, ER, PR, HER2 status. Why am I repeating this? Because it has been seen that in 10% of local recurrences, the expression of ER, PR, HER2 can change. Right? So the expression of ER, PR, HER2 can change, which is why we need to repeat them if there is a local recurrence. Right? Then one more type of local recurrence. This is a local recurrence where the mass has formed. Sometimes it can be a very diffuse kind of a local recurrence where it can be scattered all over the chest wall. And such a local recurrence is known as cancer in cuirass. Such a local recurrence is known as cancer in cuirass. Cancer in cuirass means when the local recurrence encases the chest wall like an armor. Right? You have spots all over the chest wall, and that is known as cancer in cuirass. Okay, encases the chest wall like an armor. The final complication which you should know about is phantom breast syndrome. And this usually occurs because of intercostobrachial nerve neuralgia. This occurs because of intercostobrachial nerve neuralgia. So the patient will complain that the patient can still feel pain in the breast, and she sometimes feels as if the breast tissue is still there. Right? That is known as phantom breast syndrome, and the most common cause of phantom breast syndrome is intercostobrachial nerve neuralgia. Okay? So these are the complications following mastectomy and axillary clearance, which you should know about. This is a very important topic. Now, when we do the mastectomy, we can also carry out a reconstruction. And I just want to show you some flaps, which I've already covered in the plastic surgery module. But just for the sake of reinforcement, I want to show you some images here. So we know that DIEP flap, that is the deep inferior epigastric artery, perforator flap, the one which is shown in the image, is the best flap for breast reconstruction. This is the best flap for breast reconstruction. We've discussed this in detail in the plastic surgery module. For more details, you can refer to that module where I've covered these flaps in detail. Tram flap, which is transverse rectus abdominis. Tram, which is transverse rectus abdominis myocutaneous flap. Transverse rectus abdominis myocutaneous flap is the most commonly used flap, but the problem is that there is abdominal wall weakness which occurs. Which is why there is a high rate of incisional hernias following tram flap. Right? And that is why we prefer the DIEP flap these days. That is why we prefer the DIEP flap because there's less abdominal wall complications. Right? This is the dissection of a DIEP flap, which I've again covered in the plastic surgery module. This was another patient of mine that we did a tram flap, a transverse rectus abdominis myocutaneous flap was done for this patient. So these are the various reconstructive options following mastectomy, which you should know about. Now, at the starting of the module, I told you that surgery involves surgery for the primary tumor, and we have to carry out surgery for the lymph nodes. So how do we approach lymph nodes in a patient who has breast cancer? So if enlarged or palpable lymph nodes can be there, or the patient can have non-palpable lymph nodes, right? No enlargement of lymph nodes, or there can be no enlargement. No enlargement means N0 status, N0 axilla, okay? Now, if there is N0 axilla, these patients will go for sentinel lymph node biopsy. All these patients land up with sentinel lymph node biopsy, which I'll talk about just in 1 minute time. But what if the patient has enlarged or palpable lymph nodes? So these days, if we are getting any patient who has enlarged or palpable lymph nodes, we will carry out an ultrasound-guided FNAC. If this ultrasound-guided FNAC is positive, then this patient goes for axillary lymph node clearance, which I've already discussed with you. I've told you that lymph nodes are removed. But if the ultrasound-guided FNAC is negative, then even in palpable lymph nodes, we can carry out sentinel lymph node biopsy. Okay, so this is how we approach the axillary lymph nodes in a patient with breast cancer. Now, what exactly is sentinel lymph node biopsy? So, sentinel lymph node biopsy means sentinel lymph node means that the first draining lymph node from the cancer. Now, what exactly is sentinel lymph node biopsy? So, sentinel lymph node biopsy means sentinel lymph node means that the first draining lymph node from the cancer is the sentinel lymph node or the guardian lymph node, right? This is what is guarding the body against this tumor. Okay? This concept was described for the first time at Cabana. This is also been asked. Cabana was the surgeon, and the cancer in which he described this concept was penile cancer. The other cancers where this concept is used are vulvar cancer. Vulvar cancer has been asked in the AIMS exam. It is also used for malignant melanomas, breast cancer, penile cancer, vulvar cancer, and head and neck cancers. Vulvar, I've told you, has been asked twice in the AIMS exam as well. Okay. So these were the basics of sentinel lymph node biopsy. I've already told you the indications for sentinel lymph node biopsy in breast cancer, right? Where it is in zero axilla, where no lymph nodes are enlarged, or if negative on FNAC, if you have palpable lymph nodes, but they are negative on FNAC, then also we can carry out sentinel lymph node biopsy. Now, sentinel lymph node biopsy, basically in breast, what is done is, like supposing wherever the tumor is, irrespective of the tumor site, the dye is injected in the periareolar region. We injected in the periareolar region, and this travels to the axilla. Okay? And when we open the axilla, we identify this sentinel lymph node or the first draining lymph node or the guardian lymph node. And we are going to send the sentinel lymph node for a frozen section. Okay. Frozen section also, I'll tell you certain points about it in 2 minutes. But frozen section essentially means that I send it to the pathologist, and during surgery, within 45 minutes, I get a call from the pathologist, and he or she tells me whether the lymph node is positive for cancer or negative for cancer. Okay. So if it is positive for cancer, that means if the guard is positive for cancer, then the other people in the house are at risk of cancer, right? So we will have to carry out axillary lymph node clearance. But if the guard is negative for cancer, then other people are safe and no need for clearance. No clearance, right? And what will be the advantage of no clearance? The advantage would be less lymphedema rates. So that is the biggest advantage of sentinel lymph node biopsy, that there are less lymphedema rates if the lymph node comes out as negative. Now, frozen section is used in various cancers for various purposes. First of all, whenever we have to send a specimen for frozen section, it is sent in a bottle without formalin. No formalin is added when we are sending for frozen section. No formalin, no saline when we are sending for frozen section. We just send it in a container without any formalin or saline. And frozen sections basically tell us are used for sentinel lymph nodes. The uses are for sentinel lymph nodes, whether it's tumor in the sentinel lymph node or not. For margins, it will tell me if the margins are clear for cancer or not clear for cancer. If there is any operative surprise which is there, like supposing I'm doing a surgery and I find a tumor which was not documented in the scans. So, and I want to be sure whether it is cancerous or not cancerous, then also I will send it for frozen section. Similarly, supposing I'm doing a Whipple surgery and we notice that there is an omental nodule which wasn't there on the PET scan. So I can send that for frozen section to see if it's positive for cancer or negative for cancer. Okay. So these are the uses for frozen section. Uses of frozen section, and no formalin or no saline will be set out frozen section. Coming back to sentinel lymph node biopsy, I've told you the concept. Now, when we open the axilla, of course, the lymph node will not have written on it that I'm the first lymph node, right? They're not going to raise their hand. So how do we find out which is the first draining lymph node? So the first by which we can do that is the blue dye technique, right? Is the blue dye technique. And I've also shown you in the video when I was injecting the blue dye. The blue dye which is used is the methylene blue. This is most commonly used. Methylene blue is the one which is used most commonly. Or we can use isosulfan blue. Or we can use these are the blue dyes which can be used, and it is injected in the subcutaneous plane in the periareolar region, right? Subcutaneous plane in the periareolar region is where we inject it, and usually 1.5 to 2 cc is injected. Okay. So I'm going to inject this dye, then I massage that area, and within 20 minutes or so, 15 to 20 minutes, the dye travels to the axilla. And when I open the axilla, you can see in this case the lymphatics being beautifully highlighted, and you can see these blue lymph nodes. Okay. So whichever lymph nodes are blue in color, the blue lymph nodes will be my sentinel lymph nodes. And these are the ones which I'm going to send out for frozen section. What are the complications of blue dye technique? So they can be skin tattooing. This is the most common complication of blue dye technique. They can be skin tattooing. Mark can persist for a few weeks to months. Anaphylaxis. And I have seen one case of anaphylaxis with blue in America. So anaphylaxis does occur, which is why we have to be very careful. And there can be bluish discoloration of urine. So which is why we tell the patients beforehand that in the evening when you pass urine for the first time, you can have greenish or bluish urine. And please don't be surprised because it is just the dye which is getting eliminated. Because sometimes, we get panic calls from the patient and they say, look, I'm passing bluish urine or greenish urine. I thought you were going to operate on the breast, but what has happened to my urine color? So that is why we inform them beforehand that they can have this discoloration. The other method is the radionucleotide method. In the radionucleotide method, we inject a technetium 99 tag sulfur colloid. We inject a technetium 99 tag sulfur colloid, and this is also injected in the periareolar region. And when we inject this, we are going to use a gamma camera to detect radioactivity, right? We are going to use a gamma camera to detect radioactivity. And I'll show you a video where this gamma camera is used. And when you place this gamma camera, when you place it close to the lymph node which has taken up maximum radioactivity, it will make a sound, right? Tick, 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 kind of sound it makes. So we get to know which is the hot lymph node. By hot lymph node, I mean the one which has maximum radioactivity. The one which has maximum radioactivity, those will be my sentinel lymph nodes. So let's just see that video of how this gamma camera looks like and what is this reading which I'm talking about. So you can see this video. This is the gamma camera or the gamma probe which is used for sentinel lymph node biopsy. And when we come close to the node, you can see a high reading. You can suddenly see a high reading when we come close to the node. When we remove the node and then we put the probe again there, then you will see that the reading falls down. The reading is fallen down. Now you can see the reading has fallen down once we remove the node. So this is how we carry out the radionucleotide technique using a gamma camera. Now, if you've seen this TV series called Chernobyl, in one of the episodes when the nuclear plant blows up, 3 guys are given a Geiger counter and they are asked to go and find out the source of the leak. And when they reach close to the reactor, the Geiger counter just goes berserk and you can hear this tick, 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 tick kind of a sound. So a similar sound we hear when we approach the sentinel lymph node. That is the sound which we hear, and that is how we find out the hot lymph node. Now, one thing which I wanted to know that the best technique for sentinel lymph node biopsy is the combination technique. Is the combination technique of blue dye plus radionucleotide. This has also been asked in the exam. Blue dye plus radionucleotide combination technique is the best technique for sentinel lymph node biopsy. Another technique which is becoming very popular these days is the ICG technique. This is the indigo cyanine. This is the indigo cyanine green technique. Right? So ICG is a dye which I again inject in the periareolar region and I also inject methylene blue. So I see the blue lymph nodes, but on this special filter, special light, these lymph nodes will shine green in color. They'll look emerald-like, right? And you can see in this image for one of my patients where these lymph nodes, only when I use that special filter, they were appearing this apple green in color. And this is known as the ICG technique, which is also becoming very popular for sentinel lymph node biopsy. This is just injecting the dye. So we always inject in the periareolar region, no matter which dye you're injecting. And you can see the bluish lymph node, which you can see. One more technique for sentinel lymph node biopsy is the CentiMag technique. The CentiMag technique, we use ferric oxide compounds. Right? We use ferric oxide compound and we inject it in the periareolar region. And we use a magnetic scanner to at the sentinel lymph node. Now, the advantage of Senti-MAC technique is that there is no radiation exposure. There is no radiation exposure. So that is the advantage of the Senti-MAC technique for sentinel lymph node biopsies. So these were the various techniques which are used for sentinel lymph node biopsies. One more question which you should know about, that the most common complication of sentinel lymph node biopsy in breast is ICBN injury, intercostobrachial nerve injury, which I told you, this is the most common nerve injury complication. So this is the most common nerve injury complication which can occur following sentinel lymph node biopsy, that is ICBN injury. Also, you should know that usually more than one sentinel lymph node is there. More than one SLN is present. Okay? So usually there's more than one sentinel lymph node which is present, which is obvious. Like you have a morning shift guard and you have an evening shift guard. Similarly, lymph nodes are also multiple. You can have multiple sentinel lymph nodes. Okay? So this was regarding sentinel lymph node biopsy, which is a very important topic for the INI-CD exam. Last 5 years, all 5 years, questions from sentinel lymph node biopsies have been there. So that was the surgical management of breast cancer, where we've spoken about breast conservation surgery, mastectomy. I've shown you the videos, and I've spoken about sentinel lymph node biopsy and axillary clearance. The other treatment modality is chemotherapy. And the indications for chemotherapy in breast cancer are positive lymph nodes, locally advanced breast cancers, ER/PR negative tumors, and HER2/neu positive tumors. So these are the indications for chemotherapy in breast cancer. Locally advanced breast cancers, I will cover in detail what do I mean by locally advanced breast cancers, because this is again a very common topic from which questions are asked. Okay, so right now you can just note this down. I'll tell you the details of locally advanced breast cancer towards the end of this module. So these are indications for chemotherapy which are there. Now, what we usually use is a chemoport to give chemotherapy, right? Chemoport I've also highlighted in the nutrition chapter, where I told you about central lines and central line insertion. I've shown you a video of chemoport insertion there as well in the nutrition module, so you can check that module out for central line insertion. So this is a chemoport which we put in. We create a pocket for it below the clavicle, and that's where this port is put. And this is the catheter which lies in a central vein, So whenever we have to give chemotherapy, we just put a needle into the port and we can give chemotherapy. And the advantage is that we are not rogering the peripheral lines. Okay, chemotherapy are very harsh medicine, and when you give them to the peripheral route, there can be thrombophlebitis. Which is why we use chemoports or PICC lines to give chemotherapy in patients. So what are the various chemo regimes which can be used for breast cancer? So when we were undergraduates or postgraduates, at that time, CAF or CMF regimes were used, where C was cyclophosphamide, A was adriamycin, and F was 5-fluorouracil. C was the same here. M was different. M was methotrexate, and F was also 5-fluorouracil. So these are the regimes which were used long time back. And a couple of questions which I want you to know here. Cyclophosphamide, the typical side effect of cyclophosphamide, which has been asked in the exam, is hemorrhagic cystitis. Lots of questions have been asked regarding hemorrhagic cystitis. You should know what is the compound which gives rise to hemorrhagic cystitis, or the metabolite. Compound or metabolite is known as acrolein. And the preventive agent has also been asked. The preventive agent is known as Mesna. So this you should know about cyclophosphamide. These questions have been asked. Adriamycin, another question which has been asked is that it can give rise to dilated cardiomyopathy. So these are the traditional regimes which were used. These days, what we use is AC followed by T. So it is Adria and cyclophosphamide, Adria or cyclophosphamide, or EC. E is epirubicin or cyclophosphamide, followed by T. T is taxanes, right? Taxanes can either be docetaxel, or it can be paclitaxel. So docetaxel or paclitaxel is used. This has better response than the conventional regimes. Now, paclitaxel, a side effect which you should know about is neuropathy. It can give rise to neuropathy, right? And I have a lot of patients who are doctors and surgeons, especially gynecologists, and we are very careful that whenever we get a gynecologist who's going to get chemotherapy, we don't use paclitaxel, right? Because they will be operating later on, and we don't want neuropathy in their fingers, so that they can't hold instruments or they can't feel the structures. That is why we avoid paclitaxel if we are getting a doctor certification. We ask the profession. Like I also have a painter who's my patient, and she makes beautiful paintings. And in that patient also we avoided paclitaxel because we didn't want neuropathy. You should also know that if the patient is HER2 positive, if the patient is HER2 positive, then along with chemotherapy, we have to also use HER2 directed therapy. HER2 directed therapy has to be used, and this HER2 directed therapy is Herceptin. or trastuzumab, right? Or trastuzumab. And this Herceptin or trastuzumab is given for 1 year. Herceptin or trastuzumab is given for 1 year. And the side effect of Herceptin or trastuzumab is cardiotoxicity. In cardiotoxicity is the side effect. Which is why we do repeated echos every 2 to 3 months. We repeat an echocardiogram to see for cardiac function. There is a new HER2 directed medicine also which is being used, which is known as pertuzumab, right? Which is pertuzumab or Perjeta. And Perjeta is also against HER2/neu, and a combination of trastuzumab plus Perjeta gives better response than only trastuzumab, right? I will talk about Perjeta later on as well. So these are the various chemo regimes which can be used in patients. Now, whenever we come across a breast cancer patient, and whenever you ask them that which was the most dreaded part of your treatment, all of them would say chemotherapy, right? So, if given a chance, all of them would like to avoid chemotherapy. So that is a very important point which we want to discuss. That what are the conditions where chemo can be avoided? Chemo can be avoided in which subset of breast cancer patients? This is important. Number one, those who are elderly patients with poor performance status. Right? So usually the patient is about 70 years of age, and performance status I've covered in a lot of modules. I've told you about performance status. That basically means how functional the cancer patient is. And I've told you the scores. I told you about Karnofsky score and the ECOG score. This is covered in the case presentation modules as well. So if the patient is not able to carry out their routine activities, cannot even get up and go to the toilet, how will they tolerate chemotherapy? Okay. So elderly patients and patients with a poor performance status, we avoid chemotherapy, right? Because complications will be worse than the disease itself. And the second subset of patients is early breast cancer with a favorable profile. And who are these early breast cancers with a favorable profile? So T1, T2, who are N0, or there are certain tests for N1 as well, but let's consider N0. M0, that is no metastasis, and ER/PR positive, HER2/neu negative, or ER positive, PR negative, HER2/neu negative, right? These are the patients where we can do molecular tests, to avoid chemotherapy. Okay. So these early breast cancer patients, if breast cancer is picked up early, then molecular tests can be done to avoid chemotherapy. I'll tell you about these molecular tests, but basically what we get to know from these molecular tests, we get to know if there is a high recurrence rate. So these molecular scores tell me there's a high recurrence rate, or there is a low recurrence rate, or there is a low recurrence rate or low recurrence risk. Right? So this is what we get to know. If tests show that there's a high recurrence risk in that patient, then that patient will get chemotherapy. But if it is low recurrence risk, then we can avoid chemotherapy in these patients. Okay. So that is the advantage of picking up cancers early. Some of these molecular tests, the names have been asked in the AIIMS exam. Oncotype DX is a 21 gene assay. Mamaprint is a 70 gene assay. Okay, is a 70 gene assay. These two are the most popular tests which are there. And you should also know that Oncotype, now there is data for 1 to 3 positive lymph nodes as well. Right? So even for N1 patients, we can do Oncotype DX. But as far as your exam is concerned, please remember it is T1, T2, N0, M0, ER/PR positive, or ER positive, PR negative. Endocritic is a 12 gene assay. PAM50 is a 50 gene assay. And CanAssist is an Indian test. It is an Indian molecular test which is being done for early breast cancer, and that tells us whether there's a high risk of recurrence or low risk of recurrence. So you can see this is a sample report of CanAssist. I do send out Oncotypes and CanAssist routinely. Oncotype, the only thing is that they are very expensive. So this was a patient of mine where the tumor size was 3 into 2.5 into 1. So it was T2N0 M0. ER positive, HER2 negative patient. And you can see this is how we get the report. So we get a score. The score was 11.2 and it was low risk of recurrence. So because of low risk of recurrence, we avoided chemotherapy in this patient. So this is just a sample report of one of my patients. And if we get a low risk score, we can avoid chemotherapy. The next modality is radiotherapy. And radiotherapy, the indication for radiotherapy in breast cancer are positive lymph nodes. If the tumor is more than 5 centimeters, if it is a local advanced breast cancer, again, which I'm going to cover in some time, and after breast conservation surgery. So I told you all patients who are undergoing breast conservation surgery will get radiotherapy. Now, the types of radiotherapy which can be used in breast cancer, you can either have whole breast irradiation, you can either have whole breast irradiation, that means the entire breast is irradiated, or they can be ABPI. ABPI is accelerated partial breast irradiation. This is accelerated partial breast irradiation. So these are the two modalities which are there: whole breast irradiation and ABPI, that is accelerated partial breast irradiation. Now, whole breast irradiation, as the name suggests, this would be given to the entire breast. And in certain situations, the supraclavicular and the infraclavicular fossa are also covered. The supraclavicular and the infraclavicular fossa are also covered. Whereas accelerated partial breast irradiation means that it is just given to the tumor bed area where the tumor was and the surrounding tissue. So this is the tumor. Okay. So you can see here in ABPI, ABPI is a type of brachytherapy. Brachytherapy, you would have been taught by Dr. Mayur about the types of radiotherapy techniques. And brachytherapy is when we are putting in electrodes or implanting electrodes directly into the tumor bed. And you can see that the electrodes are put directly into the cavity and it will just irradiate this area, just this much area, not the entire breast also. So that is accelerated partial breast irradiation. Now, whole breast irradiation is usually 25 days, whereas accelerated partial breast irradiation is just a 5-day sitting. So that is the advantage. There is better compliance when accelerated partial breast irradiation is done because the patient just has to come to the hospital for 5 days. This is around 55 days of radiotherapy, whereas this is 30 to 35 days of radiotherapy. And this is one fraction per day, whereas in ABPI it is two fractions per day. It is two fractions per day. So these are the two types of radiotherapies which are there. Accelerated partial breast irradiation cannot be used in all patients. So what are the indications for accelerated partial breast irradiation? The indications are the patient should be 50 years or more, 50 years or more. It should be a T1 disease. There should be no LDI. LDI is lymphovascular invasion. No lymphovascular invasion. It should be ER positive disease, and it should be a unifocal tumor. It is not done in multifocal tumors. Right? So all the criteria should be met. Then only we carry out accelerated partial breast irradiation in patients. In fact, accelerated partial breast irradiation was used a lot during COVID times because to call the patient every day for 25 days was a challenge during COVID, which is why the 5-day regime, the APPI regime, was used quite frequently. So these are the radiotherapy techniques which can be used for breast cancer. Moving on to hormonal therapy, which is the last modality which is there for the treatment of breast cancer. And hormonal therapy is only used in ER/PR positive patients. Only used in ER/PR positive patients. So if the patient is ER/PR positive, then the patient is for hormonal therapy. If the patient is menopausal, then we use a different agent, and we use a different agent if the patient is post-menopausal. If the patient is post-menopausal. So if the patient is premenopausal, there are two sources of estrogen. One is the ovary, and the second is the peripheral conversion. Right? So in the premenopausal, the estrogen is coming from the ovaries and from peripheral conversion. So I would need to block the receptors, which is why in premenopausal patients we will use SERMs. And SERMs have been covered in great detail by Dr. Ranjan. So these are selective estrogen receptor modulators. Selective estrogen receptor modulators. I'll tell you the important points which you need to know for your exam. So SERMs, the most commonly used SERM is tamoxifen. And tamoxifen is given in these patients. Earlier it was given for 5 years. But now in select group of patients, we are using it for 10 years. So now hormonal therapy extends over 10 years. Now tamoxifen is given 20 milligrams every day. Right? 20 milligrams every day. And there are certain side effects of tamoxifen which have been asked in various exams. The most common side effect of tamoxifen is hot flashes, and this is something which students should remember because I've seen a lot of them marking endometrial hyperplasia. Endometrial hyperplasia is not the most common complication. The most common complication is hot flashes. There can be endometrial hyperplasia because of tamoxifen, which is why we have to monitor the endometrial lining every 3 months in these patients. And there is increased risk of deep venous thrombosis as well when the patient is on tamoxifen. So this was for premenopausal patients. In postmenopausal patients, what happens? That nature has switched off the ovaries, right? After menopause, the ovaries have been switched off by nature. So there is just one source of estrogen, and that is peripheral conversion. So peripheral conversion is done by the enzyme aromatase, right? Is done by the enzyme aromatase. So what do we need to use? We need to use aromatase inhibitors in these patients. So we need to use aromatase inhibitors. And what are the examples of aromatase inhibitors? You have letrozole, you have letrozole, you have anastrozole, and you have exemestane. These are the 3 aromatase inhibitors which you should know about. Again, earlier these were used for 5 years. Now in select group of patients, we use them for 10 years. And the most common side effect of aromatase inhibitors, what we tell our patients, the most common side effect is osteoporosis, which is why before I put my patients on aromatase inhibitors, I would always do a bone density test. We will always do a bone density test to see what their baseline bone density is. And if their baseline bone density is less, we need to supplement the bone density. Otherwise, they can have osteoporotic complications. So these are the various hormonal therapy options which are there. With this, I've covered the 4 modalities which are used for breast cancer management. Now, what am I going to do? I'm going to summarize the treatment for each subset because when you will be asked clinical questions, you will be asked about a particular stage. And breast cancer clinical questions are very, very common. So first, let's talk about early breast cancer. Treatment summary of early breast cancer. Early breast cancer is T1, T2, N0 or N1, M0. This comprises early breast cancer, right? There is another subset known as T3, N0, M0. This is known as large operable breast cancer. Large operable breast cancer. Now, these early breast cancer patients, how do we manage them? So the surgery which will be done for early breast cancer patients is breast conservation surgery. Breast conservation surgery is what you're going to prefer. BCS is contraindicated. If BCS is contraindicated, then we will carry out mastectomy in these patients. And for the lymph nodes, if it is N0, then we will carry out sentinel lymph node biopsy. So that is the surgery which will be carried out. Chemotherapy. Patients who are T1, T2, N0 or N1 with M0 and ER and for Now, these early breast cancer patients, how do we manage them? So, the surgery which will be done for early breast cancer patients is breast conservation surgery. Breast conservation surgery is what we're going to prefer. BCS is contraindicated. BCS is contraindicated. Then we will carry out mastectomy in these patients. We will carry out mastectomy. And for the lymph nodes, if it is N0, then we will carry out sentinel lymph node biopsy. So that is the surgery which will be carried out. Chemotherapy. Patients who are T1, T2, N0 or N1 with M0 and ER-PR positive or ER positive, PR negative. These I told you, these are the patients who are candidates for which test? Correct. These are patients who are candidates for the molecular test to avoid chemotherapy, to avoid chemo. And I've told you about the molecular. If triple negative breast cancer or 3 are negative, or if HER2 positive is there, or if lymph nodes are positive, then these patients are going to get chemotherapy. These patients will get chemotherapy. And HER2 patients, Herceptin or trastuzumab will also be added. Herceptin or trastuzumab will also be added. But if you remember I told you if HER2 is 2+, what will we do? We will do FISH. We will do FISH first before giving Herceptin. FISH is fluorescent in situ hybridization. There was a question which was asked at the exam when they had said HER2 is 2+. And a lot of students marked that we will give Herceptin. No, in 2+, we will first do FISH, that is fluorescent in situ hybridization. Radiotherapy. So radiotherapy will be used if BCS has been done, if positive lymph nodes are. We will first do FISH, that is fluorescent in situ hybridization. Radiotherapy. So radiotherapy will be used if BCS has been done, if positive lymph nodes are there, then we will give radiotherapy, and hormonal therapy only if ER-PR positive patients. Only ER-PR positive patients we're going to use hormonal therapy. So this was the treatment summary for early breast cancer. Now, very important is locally advanced breast cancer. Very important for the exam. So what is the definition of locally advanced breast cancer? It is T3N1F0 or any T4, any N2, any N3 with M0. This makes it locally advanced breast cancer or LABC. So the definition alone has been asked at least 5-10 times in the exam. It's the classical example of locally advanced breast cancer, where you can see PDO. PDO is puny orange appearance, right? PDO is puny orange appearance, and that would make it T4P. So any T4, any N2, any N3 with M0, T3, N1, M0 means more than 5 centimeters in positive lymph nodes will make it locally advanced breast cancer. And treatment summary for locally advanced breast cancer is very simple. Locally advanced breast cancers get NACT, neoadjuvant chemotherapy. They will get neoadjuvant chemotherapy. We will shrink the tumor. Then we will carry out surgery in these patients, which is usually mastectomy, but BCS can also be done. In select patients, it is usually mastectomy. That would be then followed up with hormonal therapy if the patient is ER-PR positive. If the patient is ER-PR positive, I've already told you if the patient is HER2 positive, then Herceptin is to be added. Herceptin in these patients or trastuzumab in these patients. So that was the summary of locally advanced breast cancer, which has been asked many times in the exam. Metastatic breast cancer. Metastatic breast cancer is when it is M1. We've already discussed the most common site is to the bones. Now, metastatic breast cancer, the management is mainly palliative in nature because we cannot cure metastatic breast cancer. We can only control it. We can improve the quality of life. So it is palliative in nature, and it can either be palliative chemotherapy. Or we can give radiotherapy to bony mets. If there is a risk of fracture, we can give radiotherapy, or it can be hormonal therapy if the patient is ER-PR positive. So these are the palliative options which we have in patients with metastatic breast cancer. Now, if the patient is ER-PR positive and there no visceral crisis, no symptomatic disease, then we just start with hormonal therapy. Otherwise, we're going to give chemotherapy in these patients as well. Now, there are certain newer agents which are being used for metastatic breast cancer, and I want to know about these newer agents because lots of times this question has been asked in the exam, whether you want to call it pharma question or surgery question, or now in the next era integrated questions. I want you to know about these newer agents. The first agent is palbociclib. This was asked in the All India exam. Palbociclib is a CDK 4 and 6 inhibitor, CDK cyclin dependent kinase 4 and 6 inhibitor. And palbociclib is used in metastatic CA breast, which are ER/PR positive, and HER2/neu negative, and it is used along with hormonal therapy. It is used along with tamoxifen or aromatase inhibitors. We are going to use palbociclib. So this is one of the agents which has been asked in the exam. It is a CDK4/6 inhibitor. Another agent starting with P is pertuzumab. It's pertuzumab or Perjeta, and this is against anti-HER2/neu, and this is used along with Herceptin or trastuzumab. Okay. So when you use it along with Herceptin or trastuzumab, it shows better effect than only trastuzumab. You should know about lapatinib. It is not a new agent. It's an old agent only. It's an oral HER2/neu agent. And lapatinib can also cross the blood-brain barrier, so it can even act on cerebral metastasis, brain metastasis in HER2/neu positive patients. Another agent is atezolizumab. Atezolizumab is the first immunotherapy for triple negative patients, immunotherapy for triple negative breast cancers, TNBC, and this is a PDL1 inhibitor. This is a PDL1 inhibitor. So atezolizumab is used in triple negative breast cancer patients. Another newer agent is alpelisib. Alpelisib is also used for metastatic. It is also used for metastatic ER/PR positive patients. And this one is a PI3K inhibitor, right? Alpelisib is a PI3K inhibitor. This has also been asked in the exam. And finally, you should know about olaparib. Olaparib is a PARP inhibitor, and this is used in BRCA positive metastatic patients. So these are some newer agents which you should know about pertaining to breast cancer, from which questions have been asked or can be asked in the exam. Now let's talk about certain special situations pertaining to breast cancer which are important for your exam. So the first special situation which I want to talk about is pregnancy-associated breast cancer. Now, pregnancy-associated breast cancer is breast cancer which develops during pregnancy or within 1 year of delivery. So breast cancer during pregnancy or within 1 year of delivery is pregnancy-associated breast cancers. These are usually ER/PR negative and they are aggressive tumors. So just to share with you, just in the last 3 months, I've seen 2 pregnancy-associated breast cancer patients, and they usually develop lumps in the second or the third trimester. And because the breast is also getting engorged because the pregnancy changes, these lumps are usually masked. They don't get to know about them. Okay? Which is why I request all gynecologists to do a breast examination in each trimester of every pregnant patient to make sure that they are not developing lumps. So ER/PR negative, usually aggressive tumors. The imaging investigation of choice is ultrasound. Is the imaging investigation of choice because we will not do mammography. We do a core needle biopsy to confirm the diagnosis. Core needle biopsy or true cut biopsy is done to confirm the diagnosis. Now, the management of pregnancy-associated breast cancers, surgery. So surgery, breast conservation surgery is contraindicated because radiotherapy cannot be given, because RT cannot be given. Radiotherapy cannot be given during pregnancy. But if the patient is diagnosed, in second or third trimester, if the patient is diagnosed in second or third trimester, then we can do BCS. Then BCS can be done and radiotherapy after delivery. So this pregnancy-associated breast cancer was a fair topic of the PGI exam. Every year they used to ask a question from pregnancy-associated breast cancer. So this can be asked in the INI-CET exam if this topic is important for that exam. Now, if you're not doing BCS, then we will carry out mastectomy in these patients. Chemotherapy, we know, is avoided in the first trimester because of organogenesis. We avoid in the first trimester. Avoided in first trimester because of organogenesis. It can be used in second and third trimesters. We can do chemotherapy. So for one of the patients I was telling you about, whom we had picked up in the second trimester, because it was a locally advanced breast cancer, we started her on chemotherapy. So she's currently undergoing chemotherapy. She's still pregnant. So it can be given in the second or the third trimester under monitoring. Hormonal therapy and radiotherapy are contraindicated in all trimesters. In all trimesters of pregnancy, hormonal and radiotherapy are contraindicated. So this was regarding pregnancy-associated breast cancer, the summary for that special situation. There are patients who can develop bilateral breast cancers as well, and this is usually seen in patients who are BRCA positive. These patients can be BRCA positive, and in my practice till now, I have 7 patients who are bilateral breast cancers. Okay, so bilateral breast cancer, if you diagnose them simultaneously bilateral breast cancers, lobular cancers are common because lobular, I told you, tend to be bilateral and multicentric, and the treatment in these patients is governed by the larger tumor. So whichever side is the larger tumor or the more aggressive tumor, that will cover the treatment of the overall breast cancer treatment in these patients. Male breast cancer, the incidence of male breast cancer is 1%, and this was a patient of mine. Another case which I saw during my post-graduation, you can see that this elderly male had a locally advanced male breast cancer. Now the risk factors for male breast cancers, the risk factors are BRCA2 mutation, more common than BRCA1 mutation, Klinefelter syndrome. So Klinefelter syndrome, the gynecomastia which you see in Klinefelters can give rise to breast cancer as well. Liver cirrhosis is a risk factor, and obesity is also a risk factor in these patients. So these are some of the risk factors for male breast cancers, and you should know that the diagnosis, the management, the prognosis is the same as female breast cancer. So we manage them exactly the same way. There is a male patient of mine who's a lawyer, and he gave him tamoxifen, and he experienced hot flashes. So, he came back and told me that he finally got to know what his mother felt like when she was going through menopause. Right? So these patients are given exactly the same treatment, including hormonal therapy as well. Now, the next thing we need to talk about is DCIS. DCIS is ductal carcinoma in situ. So this is ductal carcinoma in situ. That means it hasn't invaded the basement membrane. Now, what are the types of ductal carcinoma in situ which you should know about? So the papillary type of DCIS is most common. You can have cribriform, they can be solid, and they can be comedo. Now, comedo with necrosis is the most aggressive type of DCIS. And this is the type of DCIS which usually presents as a lump. Otherwise, the other types of DCIS, they usually come with pleomorphic microcalcifications, which I will just show you. Comedo type of DCIS is usually ER/PR negative. The other 3 types of DCIS, papillary being the most common, these are usually ER/PR positive. And the most common presentation of DCIS is in the type of microcalcifications on a mammogram. So you can see these clustered microcalcifications or pleomorphic microcalcifications are representative of DCIS. Now, how do we confirm the diagnosis? The diagnosis is confirmed by an image-guided biopsy of the lesion. So because the patient is coming with microcalcifications, I cannot palpate microcalcifications. So to biopsy these areas, I need to do image-guided biopsy. So we do an image-guided biopsy to confirm the diagnosis. And once we've confirmed the diagnosis of DCIS, then we have to manage these patients. So management of these patients can be surgery. So there can be surgery. Now, surgical options for DCIS are we can either do breast conservation surgery or we can do a simple mastectomy Okay. Now, breast conservation surgery, we've already discussed. We just remove the lesion and remove tissue around it. And breast conservation surgery, radiotherapy is mandatory after breast conservation surgery. This is also we have discussed previously. Why simple mastectomy? Because it is in situ, so we don't need to clear the lymph nodes. We don't need to clear the lymph nodes in DCIS. So that is why simple mastectomy is done. And if simple mastectomy is done, it has the least loco-regional recurrence rate. It has the least loco-regional recurrence rate. LRR is loco-regional recurrence rate is least if mastectomy is done. This question has been asked in the exam. Now, please remember there is absolutely no role of chemotherapy. Very important. This was asked in the AIMS exam and the PGI exam that there is no role of chemotherapy in DCIS. It is an in situ cancer. We only do surgery is done and hormonal therapy is done. Radiotherapy is done. No role of chemotherapy in DCIS. Please remember that. Radiotherapy, I've already told you after BCS, you have to do radiotherapy, breast conservation surgery. And hormonal therapy is given if the patient is ER/PR positive. Then we will give hormonal therapy. So this is the treatment summary for ductal carcinoma in situ. There's another thing in DCIS for which lots of questions have been asked, and this is the Van News prognostic index in DCIS. This was asked in the All India exam 3 years back. So the point which you need to know in DCIS is in Van News prognostic index for DCIS. Is that what all is included? So size is included, margins are included, grade and type, grade and necrosis are included, and age is included. Please remember that ER/PR status is not included. ER/PR status is not included in Van News prognostic score. And if you get a high Van News prognostic score, then it is worthwhile doing a mastectomy for these patients. If it's a high Van News prognostic score, then it is worthwhile doing mastectomy. And if it's a low risk score, then RT can be avoided. RT can be avoided if it is a low Van News score. There are certain studies which are saying that radiotherapy will be avoided in these patients. So this was regarding ductal carcinoma in situ. Now, lobular carcinoma in situ. Lobular carcinoma in situ is the last thing which we need to discuss in this module. And I've already told you that in the 8th HSCC classification, lobular carcinoma in situ is now considered as a benign condition. It is a benign condition with a risk of cancer. It is a benign condition with a risk of cancer. It is no longer considered as an in situ lesion. Now, lobular carcinoma in situ tends to be bilateral and multicentric. bilateral and multicentric, and it is usually an incidental diagnosis. It is usually an incidental diagnosis. That means we are doing surgery for some other thing, and we'll find out that the patient has LCIS. It can sometimes present as a lump. Sometimes it can come as a patient can come as a lump. Otherwise, mostly it is an incidental diagnosis. Now, how do we manage LCIS? So, if LCIS is detected incidentally, and if it is at the margin of the resected specimen, means it is reaching up till the margin of the resected specimen, no further resection is to be done. We don't need to further resect LCIS. We will just keep the patient under surveillance. Similarly, if LCIS is diagnosed on biopsy, the patient is kept under surveillance. We just keep the patient under surveillance. Now, you should know that LCIS, 1% risk per year of malignant conversion. So, 1% risk per year of malignant conversion, and LCIS can get converted into invasive ductal or invasive lobular cancer. So, it is not as if it will only get converted into invasive lobular. It can also get converted into invasive ductal carcinoma as well, right? So, 1% risk per year is the risk of malignant conversion. You should also know about another new entity which has been described in pathology books and surgery books, that is pleomorphic LCIS. Pleomorphic LCIS is ER/PR negative, and it behaves like high-grade DCIS. This behaves like high-grade DCIS, which is why if pleomorphic LCIS is detected, we have to carry out resection and we have to manage like DCIS. We have to manage like ductal carcinoma in situ. That brings us to the end of this module. In this module, I've spoken about the treatment for breast cancer and the various special situations. A lot of clinical questions and clinical scenarios can be asked from this module, so you should go through it in detail. For final year students, the short notes which you should know are regarding mastectomy, regarding complications of mastectomy. Those are the major things which have been asked in the exam from this module. Now, before I move on to the MCQs, just want to share this picture. This is, of course, my two very big motivations for me in my career are, of course, the students whom I teach and my patients and my team which is there, right? So this is my team, and this is my youngest patient I've treated till now. She was 23 when she was diagnosed, And you should listen to her inspirational story on my YouTube channel, where she shared her entire story and how she continued working despite her breast cancer diagnosis. So even while you're preparing for your entrance exams or any exams, you should have a source of motivation. There should be somebody who should be your driving force, whether it is your friends, your family, or your vision for your career. So if you have a driving force, you will of course do better in life. Let's do some MCQs now. Which of the following statements regarding the management of breast cancer is not true? Maloprint and Oncotype are scores used in early breast cancer to predict the benefit of chemotherapy. This is true. Oncotype DX is a 21 gene assay used in ER/PR positive patients only. So this is now false because this can now be used for ER positive and PR negative as well. With the latest studies coming in for Oncotype, it can be used for ER positive and PR negative as well. Hormonal therapy should be given for 10 years. This is true. Overall survival after mastectomy is significantly more as compared to BCS. This is false. Overall survival is the same. A 36-year-old is diagnosed with locally advanced breast cancer. Locally advanced breast cancer, I've told you. Locally advanced breast cancer and ER/PR is positive, HER2/neu is 2+. Which of the following statements is not true? Patient will get hormonal therapy? True, because ER/PR positive patient. Will benefit from neoadjuvant? Yes, all locally advanced benefit from neoadjuvant chemotherapy. Trastuzumab is indicated? False. Remember I told you HER2/neu is 2+. So what will we do in this patient? We will first do FISH, fluorescent in situ hybridization. Radiotherapy will be required. This is true. All of the following are true about accelerated partial breast irradiation. APBI is delivered in an abbreviated fashion and a lower total dose than standard dose of whole breast irradiation. True. Suitable patients include women older than equal to 50. Years. True. Suitable patients for APBI include whose tumor margins are greater than equal to 2 millimeters. This is true. So negative margins should be 2 millimeters. At least 2 millimeters, then only we do APBI. Multifocal disease? No, we cannot do it in multifocal disease. A 42-year-old lady goes for an executive health checkup and is diagnosed with pleomorphic microcalcifications. Biopsy reveals it to be a comedo type of BCIs, which is ER/PR negative. Okay? Which of the following is not true regarding her management? Simple mastectomy is associated with least recurrence rate. This I told you is true. BCS followed by radiotherapy will be associated with least recurrence rate. No. Will not benefit from chemotherapy. True. DCIS is in situ. No role of chemotherapy here. Okay? Van News prognostic index is can be used. That is correct. It can be used in this. A patient accidentally pulls out the drain after mastectomy. Fullness develops in the region 2 days afterwards. Which statement is correct? So drain is accidentally pulled, fullness develops. That means seroma has formed. Correct. Seroma has formed. So seroma is an uncommon complication. False. It is the most common complication. It should be aspirated under aseptic conditions, followed by pressure dressings. This is true. Increased incidence is associated with increased incidence of lymphedema. False, I told you. No correlation. And drains following mastectomy should be removed when the output is less than 75 cc. False. Less than 40 cc per day for 2 consecutive days is what I told you. So these were some MCQs regarding this module. In the next module, I'll talk about the benign breast conditions and I'll talk about Paget's disease as well. Thank you. Now we move on to benign breast conditions. And in benign breast conditions, the first thing which I want you to know is regarding regarding breast abscess. So breast abscesses, you can either have lactational breast abscesses or you can have breast abscesses associated with ductal. So we just discussed the differences and the differences in management between these two conditions. Now, of course, lactational breast abscess is much more common as compared to abscesses with ductal. And lactational breast abscesses will occur in lactating mothers, and the most common organism which is implicated in a lactational breast abscess is Staph aureus. Many times in the exam they've asked, what is the source of this Staph aureus? This is a very important question. The source of the Staph aureus is the oropharynx of the child. So the infection comes from the mouth of the child and goes to the mother. So oropharynx of the child is the source of this Staph aureus. And how will the patient present? So the clinical features, the patients would present with features of inflammation. There's going to be pain, there's going to be fever, there's going to be swelling. So the patient's going to have pain, fever, swelling. But what you need to remember, that fluctuation is going to be a late sign. Fluctuation is a late sign. And remember, I told you that fluctuation is a late sign in breast, parotid, palmar, plantar, and ischiorectal abscesses, right? Fluctuation is a late sign in breast, parotid, palmar, plantar, and ischiorectal abscesses. What is the importance of knowing this? If fluctuation is a late sign, do I wait for fluctuation to occur or do I start managing the patient before that? Of course, you start managing the patient before that. Don't wait for fluctuation to occur. That is the importance of knowing this point. So, lactational breast abscess, the diagnosis is going to be with an ultrasound. And the management of these patients, you have to start the patient on antibiotics. Now, the antibiotic of choice is amoxicillin plus clavulanic acid, is amoxicillin plus clavulanic acid. But in this year's NEET exam, in the 2019 NEET exam, they had given cloxacillin as one of the options. This is also correct. So if amoxiclav is not there, you will mark cloxacillin as the answer. You have to give analgesics to these patients. If pus is there, if pus is present, mind you, we straight away don't do incision and drainage. Straight away don't do incision and drainage. At least 2 attempts of ultrasound guided aspiration should be done. At least 2 attempts of ultrasound guided aspiration of pus should be done. And if these 2 attempts fail and there is still pus there, then we do incision and drainage. Incision and drainage is done. Remember which blade is used for incision and drainage? A number 11 blade or a stab blade is used for incision and drainage. And remember, when we do an incision and drainage, you have an open wound then. And you have to discuss with the patient that we will have to do lactation suppression after the drainage. Before the drainage, patient can still feed. There is no problem. Even if the patient is feeding from that side, there is no problem. But once you've done a drainage, you should suppress lactation so that a fistula doesn't form. Right? Because you have an open wound, so milk can keep on coming out. You suppress lactation by giving cabergoline. So you should discuss that with the patient. Give cabergoline to suppress lactation. One more thing, if you have a non-healing breast abscess, like remember the example which I told you, a gynae sent me a patient, a lactating mother, where they drained the abscess, but the abscess wasn't healing. So if you have a non-healing abscess, what are the 2 things which you should suspect? You should suspect tuberculosis in a country like India, and you should suspect inflammatory breast cancer. And you should suspect inflammatory breast cancer, and you should send a biopsy from the wall of the lesion to confirm the diagnosis. So this was regarding a lactational breast abscess. You can also have breast abscesses associated with ductal. These will be seen in perimenopausal women. These are seen in perimenopausal women. And these abscesses have aerobic plus anaerobic bacteria. There is aerobic plus anaerobic bacteria in these abscesses. Diagnosis will be made by ultrasound because you will also have ectatic ducts and you will have these abscesses. as well, and management is going to be antibiotics and surgery. And you know that the surgery for ductal aphasia is Hadfield's procedure, which I'm just going to tell you in 10 to 15 minutes. I'll tell you what Hadfield's procedure is. But the reason of highlighting these two types of abscesses is that they're occurring in two different age groups. The organisms are different, and the condition and the management is different. So that is what I want you to remember regarding breast abscesses. The next thing in benign breast conditions I want you to know about ANDI. ANDI stands for aberrations of normal development and evolution. Aberrations of normal development and evolution. What does this term mean? This term means that the breast undergoes a lot of changes since development and till the time it involutes in menopause. And during this period, multiple benign conditions can occur. All the benign conditions are put under a term of ANDI. So this is a term which covers all benign breast conditions. Which covers all benign breast conditions. That is ANDI. Now, what are the things that you need to remember? That in patients who are 15 to 25 years of age, the most common problem in 15 to 25 years of age is going to be fibroadenoma. Is going to be a fibroadenoma. Other conditions are fibrocystic disease. Fibrocystic disease. There can be cysts in the breast as well. We'll talk about all of them. 25 to 40 years of age. What are the various things can be there? The most common is fibrocystic disease. Most common is fibrocystic disease. There can be a fibroadenoma. There can be cysts, and these patients can also have thyroid tumors. After 40 years of age, the most common problem in these patients is again fibrocystic disease. There can be aphasia as well, and there can be thyroid tumors as well, right? So these are the various benign conditions. You should remember the most commons in each age group. Now we'll talk about these conditions in detail. First, let's talk about a fibroadenoma. A fibroadenoma is a common short note in your college exam. It is a short case, and a lot of MCQs are also asked from fibroadenomas. So fibroadenoma is the most common cause of a breast lump, and it commonly occurs between 15 to 25 years of age. Commonly occurs between 15 to 25 years of age. The clinical features: the patient is going to come with a firm, mobile lump in the breast. The patient is going to come with a firm, mobile lump in the breast. It is usually painless. And what you need to remember is that 10% patients have multiple fibroadenomas. 10% have multiple fibroadenomas. And there was a case which I did 5 years back. It's there on my blog as well, where the patient had 39 fibroadenomas in both the breast. So there can be multiple fibroadenomas in 10% patients. Diagnosis is made by ultrasound. So this is a radiological diagnosis. You don't need histopathological confirmation. Why? Because the radiologist is going to report it as BIRADS2. BIRADS2, remember, is benign. And in a benign lump, we don't do a biopsy. There's no necessity to do a biopsy. So diagnosis can be made by ultrasound. Right? If you do mammogram, you will see popcorn calcification on mammogram. This has also been asked in the exam. Popcorn calcification on mammogram is seen in a fibroadenoma. Now, histopathologically speaking, fibroadenomas are of two types. Histopathologically, you can have a pericanalicular or you can have an intracanalicular fibroadenoma. You can have a pericanalicular or an intracanalicular fibroadenoma. This was asked in last year's DNB exam that they had asked one is the hard type. The hard type is pericanalicular. The hard type is the pericanalicular type. And the easy way to remember this is P for pericanalicular, P for patthar. Patthar in Hindi, you know, is a stone, right? So a stone is hard. So that is how you can remember it. Pericanalicular, P for pericanalicular, P for patthar. Patthar is a stone which is hard, so it is the hard type. The management of fibroadenomas, all fibroadenomas don't require excision, right? They don't require excision because the risk of malignancy is almost negligible there. So what are the indications for surgery? The indications for surgery in a fibroadenoma are cosmetic indications, right? These are in fact the most common indications. So you'll get a young girl who will say that I have a huge lump and it's a cosmetic blemish for me, so please remove it. Or if it is painful, or if there is rapid increase in size. So we usually tell ladies to monitor it with serial ultrasounds every 6 months. And if there is a rapid increase in size, that is an indication to remove it. Or if there is a family history of breast cancer. If there is a family history of breast cancer, or if it is a giant fibroadenoma. A giant fibroadenoma is a fibroadenoma more than 5 centimeters in size. This has also been asked in the exam. So these are the indications to remove a fibroadenoma. Now, what you have to understand is that these fibroadenomas are occurring between 15 to 25 years of age. And these ladies, their main concern is that there should be no scar left after surgery. So that is why for fibroadenoma, this was a patient of mine. I just want to show you that we make a periareolar incision. We make a periareolar incision to remove a fibroadenoma. And this periareolar incision is closed using subcuticular sutures. Remember, subcuticular 30 monocryl. So we use subcuticular sutures to close this. And you can see that you can hardly notice a scar. This is immediately after surgery. After 1 month, you can't even notice the scar there. So we use a periareolar incision because it is cosmetically better. Supposing the fibroadenoma is in the lower half of the breast. Supposing the fibroadenoma is in the lower half of the breast, then we can use an inframammary incision, and this inframammary incision will be hidden in the inframammary fold. Inframammary incision is known as the Gillard-Thomas incision. This is known as the Gillard-Thomas incision. Now, nowadays, another thing which you should know about is scarless fibroadenoma surgery. Scarless fibroadenoma surgery. And for scarless fibroadenoma surgery, we are either using RFA, that is radio frequency ablation. Radio frequency ablation. So radio frequency ablation, we just use a 2 or 3 millimeter incision to put in the radio frequency probe. And we just use the probe to get rid of the fibroadenoma. But the recurrence rate is reasonably high in this scarless type of technique. The scarless technique, another technique, and this is the technique which I also use for my patients, is the vacuum assisted biopsy system. The vacuum assisted biopsy system is known as a mammotome. Right? And in this we use an 8-gauge needle. And I put this 8-gauge needle, it is approximately a 2 millimeter incision, put in this 8-gauge needle, and it will take out chunks of this fibroadenoma. Right? So we remove the fibroadenoma piecemeal, and we can remove it just with that 2 millimeter incision. So I've been doing this technique for quite some time, but again, there are limitations of this technique that we can only do it for fibroadenomas which are 2 centimeters in size, and it cannot be done for fibroadenomas which are far away from the midline, and especially which are in the medial aspect of the breast. So this is the scarless fibroadenoma surgery, radio frequency ablation, and vacuum assisted biopsy system. Vacuum assisted breast biopsy system, as you can see in the image. With this system, a lot of breast-related conditions can be managed, like fibroadenomas, giant fibroadenomas, and certain things. In the first case, I'm going to show you and we managed it using the BAP system. As you can see in the image, the BAP ultrasound guidance, and you can see the probe which is inside the lesion and it cuts the lesion piecemeal. This is how the surgery is done. It is done under constant ultrasound guidance and with the tumors and anesthesia around the lesion. So this is the BAP probe, and this is how the specimen comes out. This is the beauty of surgery, hardly any scar. In the second case, I had a 21-year-old unmarried girl with bilateral fibroadenoma, diplomatic. Again, under ultrasound guidance, we introduced the probe after infiltration local anesthesia. And the probe cuts through the lesions piecemeal. The specimen gets connected behind the probe. Piecemeal. The third case was a case of a 32-year-old lady with a recurrent cyst, which was recurring after aspiration. You can see debris inside the cyst as well. It was a complex cyst, which was again managed using BAP, which is hardly a 2 or a 3 millimeter scar, which is there. Tissue comes out in a piecemeal fashion. BAP can not only be used for therapeutic indications, but also for diagnostic indications like to diagnose cancer. The advantages are that the procedure is scarless, there's less pain, it can be done as an OPD procedure. After the procedure, we do apply compression so that bleeding is not occur. Another thing which I want you to know is a phylloid tumor. So, phylloid tumor, as I told you, is occurring in ladies, and this occurs in the 3rd or the 4th decade of life. This occurs in the 3rd or the 4th decade of life. And phylloid tumors can you can either have benign phylloids, or you can have malignant phylloids, or there can be a malignant phylloids. So the differentiation between benign and malignant is based on the number of mitotic figures, present in the phylloid tumor, and this can only be confirmed on a biopsy, whether a true cut biopsy or an excisional biopsy, but not on an FNAC. So I want you to remember this. FNAC will not show me the number of mitotic figures, so there is no role of FNAC in a phylloid tumor. We have to either do a true cut biopsy or we have to carry out an excisional biopsy. Now, phylloid tumors are also known as cystosarcoma phylloids. And the clinical features of phylloid tumor, the patient is going to come with a rapidly enlarging breast lump. There's going to be a rapidly enlarging breast lump, and there will be dilated veins over the chest wall. You will see dilated veins over the chest wall. The diagnosis I told you is made by biopsy or true cut biopsy, and this is a mammogram of one of my patients who had a phylloid tumor. The reason why I wanted to highlight this is you can see how big the tumor is. It is almost covering the entire breast, so they can really become very big in size. Now, that is how we confirm the diagnosis. Malignant phylloid tumors can show hematogenous spread. Malignant phylloid tumors can show hematogenous spread, and this hematogenous spread is most commonly to the lungs. And less than 10%